afternoon. My name is Tess Taylor, and I'm a specialist in the Community Education Department at MDA. We're thrilled to have you join us for today's virtual learning event, Updates in Research and Care for Myositis. This learning event is part of our larger MDA community education program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events. We are recording today's event and we'll be posting it to the website for on-demand viewing at a later date. Everyone registered today will receive that information in their inbox. Please know that all phone lines have been muted, but you can still ask questions. You can have a Q&A session at the end of Dr. Paik's presentation. If you are logged in live, you can use the chat or Q&A feature on the webinar to type in those questions. For nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through MDA's Care Center network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through research, access to care, advocacy, education, recreation, and engagement. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. Our MDA care centers are located at over 150 top medical institutions nationwide, providing care from clinicians who specialize in neuromuscular disease. MDA's advocacy work focuses on support for accelerated approvals and novel research, access to healthcare, accessible air travel, and more. This focus plays a vital role in shaping laws and policies that support the needs of people living with rare neuromuscular diseases. Our community education and recreation programs are designed to connect individuals and families. We are committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. Every year, we offer over 40 educational programs, over 20 summer camps, and dozens of other community activities, both in person and virtually. If you haven't done so already, we invite you to join the MDA community by registering with us for free. Please see the link in the chat. To learn more, please visit mda.org. Now it is my pleasure to introduce our speaker today, Julie Paik, MD, MHS. Dr. Paik is the co-director of the Myositis Center and an associate professor of medicine in the Division of Rheumatology at Johns Hopkins University. She completed her undergraduate degree at Johns Hopkins and her medical degree at George Washington University School of Medicine. Thereafter, Dr. Paik pursued her internal medicine residency at UCLA Cedars-Sinai, West LA VA Medical Center, where she served an additional year as chief resident. She then completed fellowship training in rheumatology at Johns Hopkins and then transitioned to the faculty as a faculty member at Johns Hopkins Myositis Center. Dr. Paik's clinical and research interests are focused on neuromuscular manifestations of autoimmune diseases, particularly in the areas of myositis and scleroderma. Dr. Paik has also completed a master's in clinical investigation at the Johns Hopkins Bloomberg School of Public Health. Hi, Dr. Paik. Thank you so much for being here today. We do appreciate your time. I'll stop sharing my screen so that I can turn the time over to you.
Thank you so much for the kind introduction. Okay, I have two screens up. I think it's sharing now. Do you see my screen?
Yes, looks great. Thank you.
Okay. Oh. All right. Well, thank you so much for the kind introduction. Can you hear me well?
Yes, we can.
Okay. All right. Well, it's nice to be invited to speak here in the webinar form at the MDA. I think as an adult rheumatologist and not neurologist, we work very closely with our neurology colleagues, and I always learn from them. So it's nice to give our kind of perspective as a rheumatologist treating patients with myositis. So this is a talk on updates in research and care in myositis. These are my disclosures. And obligatory copyright material. So today I'm going to give you, the outline of my talk today is to first give you an overview of the major subgroups of myositis and their clinical phenotypes, and also discuss myositis autoantibodies and why we think they are so important, especially, I do believe that is one consensus across rheumatology, pulmonology, neurology, why these myositis autoantibodies are very important, and I'll explain why. And then I'll delve into the current treatment algorithm of myositis and exciting future therapeutics of myositis. I think it's a very exciting time in myositis in particular because we are kind of at the time point at which maybe like 25, 30 years ago, like actually it was in 1990, so maybe a little bit longer than that, but when RA had this huge boom of multiple drug companies very interested in expanding the therapeutic landscape of treating rheumatoid arthritis. So I really think we're at this kind of juncture, even in myositis. And so that's why I have a lot of enthusiasm and excitement to discuss some of the future therapeutics of myositis. So give you a little bit of background about the heterogeneity of clinical presentation in myositis. So I will say myositis is kind of the all-encompassing term that I will be using, but the real technical term we use is idiopathic inflammatory myopathy. Is idiopathic because we don't know why it starts per se. It's an autoimmune response, and suddenly your muscles get inflamed. It's not a genetic muscle disease. It's something is triggering your body to fight against your own muscles. And then you get a very heterogeneous clinical presentation, as you can see. Obviously myositis, myo meaning muscle, and itis meaning inflammation, the skeletal muscles involved, but there's a predilection for the proximal muscles, especially the neck flexors, shoulder abductors, and the hip flexors. And this can make it sometimes hard to distinguish from, limb girdle muscular dystrophy. We've definitely seen patients come to us misdiagnosed as having a limb girdle muscular dystrophy. And we're like, oh no, you actually have this form of myositis. And so I will explain why the diagnostic tools, including a myositis-specific autoantibody, is important. So I'll discuss that in a little bit. But in addition to the skeletal muscles, all other organs can potentially be involved. Certainly in one of them, you can get severe rash with dermatomyositis. And I'll show you some pictures of that. And the lung can also get inflamed. And this is all autoimmune. It's not a genetic, something you're born with. Usually our patients, the prevalence we say is about 50 to 75 per 100,000 per year. And most of my patients present in 30s, 40s, mostly women, 2 to 1. I don't usually see very young patients. Of course, I'm in the adult, side. There are juvenile cases of myositis as well, where you can get all these manifestations: skin, lung, muscle, even cardiac is something I will briefly touch on as well. But it is a very heterogeneous clinical presentation. And I think that is why, as a rheumatologist who has a background in internal medicine, it is important that on that foundation of internal medicine and thinking about a patient in multiple organ systems is very important, because if I erroneously think myositis only affects the muscle, I could be in big trouble because I could have missed lung involvement and lung scarring in a patient, even when they were talking about shortness of breath. So I think that that foundation is very important to understand, that it's a heterogeneous clinical presentation. We have to think about it as a multi-system disease beyond just skeletal muscle. Okay, that was a lot of talk for this one slide, but hopefully I can impart to you that it is important to think about multiple organ systems. So what are the main subgroups of myositis? These are the main subgroups. I would say in the past 10 years, there has been an understanding that there are many subgroups of myositis. Before, it was only, dermatomyositis and polymyositis. And that goes back to the 1970s, when there was a first classification criteria for myositis by a rheumatologist, Bowen and Peter. And that was many, many years ago. And that was updated in 2016. And it was thought, okay, now we understand. And this is something actually we learned from the neurologist a lot as well, that there's actually different subgroups of patients, like including polymyositis is really a diagnosis of exclusion. And most of these patients would actually be classified in this immune-mediated necrotizing myopathy, or sometimes we call it necrotizing myositis. And then, of course, inclusion body myositis has always been a known subgroup, even back in the 70s. But I think it is becoming more recognized that we really need to do a lot more. It's a very high unmet need in terms of understanding the disease and finding a treatment for inclusion body myositis. And I will talk about that towards the end of my talk. And then recently, I would say in the past 5 years, there's been a greater awareness that there's also a different subgroup called anti-synthetase syndrome. That's a long fancy word for synthetase are these tiny little proteins that we all learned in biochemistry, even I think in 6th grade. Good public school education in California or anywhere you are. I grew up in California, but wherever you are, the good public school, any biochemistry class would have taught us there's these amino acids or proteins, and these synthetases, these protein vehicles that attach to it, are the ones that are abnormally positive in our patients with anti-synthetase syndrome. And these patients tend to have more lung involvement. And so now it is really accepted and appreciated in rheumatology, neurology, anyone studying myositis, that this is really a distinct entity as a different subgroup of myositis as well. And the other subgroup, I think, still needs a lot of work, but it is being recognized. And I do some of this work myself, where it's this overlap myositis, and they have historically been ignored, but many of these patients can have another connective tissue disease. So you're going to be like, okay, I have one autoimmune muscle disease, but then now I have another connective tissue disease like lupus, scleroderma, rheumatoid arthritis. And that is what we define as overlap myositis, and makes it even more challenging and important to think about multiple organ systems. So those are the main subgroups. Now, this timeline is really to highlight why these myositis autoantibodies are important and how far does it go back and what is a myositis autoantibody, basically. So the first myositis autoantibody was discovered in 1972, and 1976, and you can see throughout the timeline there's been multiple discoveries throughout. Now these orange these all very unusual names, but it's MI2, NXP2, someone named after these, and it's more biochemical name, but in the rheumatology space or anybody doing myositis, neurology too, or pulmonology, when these are positive, is very highly linked to the clinical expression of the disease. So I will have a picture of that in my next slide. And that's why we order these autoantibodies. And now, since the discovery since 1976, there's so many autoantibodies that we now know that you can test for these at Quest or LabCorp or other research labs as well. But as I said, this orange is all these dermatomyositis specific autoantibodies. The green are for necrotizing myositis or immune-mediated necrotizing myopathy. And this blue one, there's only one that's blue, light blue, and that's for inclusion body myositis, as you can see here. Now, so this is like a slide that I always put in all of my myositis talks, because I always say in the myositis space, a talk is incomplete without a slide on the different myositis autoantibodies. And the reason is that, as I said, it's tightly linked to the expression and presentation of the disease. And if I know that you are MDA5 positive here in the middle, and your doctor sees that, then we're thinking, oh, this patient may develop pretty severe lung disease, and I better get a CT scan of their chest. So it's already signaling in my brain that I need to do XYZ for my patient, because I don't want any complications from this autoimmune disease that I missed because I didn't think about it from the beginning. So this is why it is part of a diagnostic workup for all of our patients to get the myositis autoantibody panel. And autoantibody meaning, let me just take a step back if I didn't explain that earlier, is when we get a vaccine, like for example, people are talking about measles, right? MMR vaccines or COVID vaccines, how do we check that we are actually had an appropriate response to actually getting measles when I was younger, or appropriate response to the measles vaccine, that I'm immune to it? And how we do that is when the virus presents itself, we actually make these antibodies or proteins against that virus so that next time I can fight that virus, right? But in an autoimmune disease, your body is actually not fighting against a virus, but you're fighting against your own muscles or your own lungs, and it makes these antibodies. And they're named all after these weird, unusual names, but these are the myositis autoantibody, auto meaning to yourself antibodies. So again, these autoantibodies here are usually associated with dermatomyositis, so you get the skin. These two are classically associated with dermatomyositis and cancer risk. And these SRP and HMGCR, a lot of letters I'm throwing out on you, are associated with necrotizing myositis. And this is IBM here and overlap myositis here. Okay, now if you do have dermatomyositis, it is important that you talk to your provider about risk of cancer. Now, this risk of cancer has always been reported in the literature since the 1970s. It's been well known that patients with myositis may have a higher risk of cancer, and especially in dermatomyositis. There's been a lot of research in this area internationally or in the United States. And the more recent study was done in the UK, and they looked at the 10-year cancer risk. And really the leading autoantibody, so if your Quest antibody panel came back and it shows TIF1 gamma, then that's the one that's the most highest risk. In some studies in France and Asia, it's even the risk of cancer from baseline goes even higher to like 30%. So whenever there is a patient with dermatomyositis that's not responding to treatment, and I'm thinking, why is she not responding? I've given XYZ and she's still not responding, then we have to think, is there an underlying cancer that's driving the disease process? So in this study done by Dr. Aldroyd in the UK, you can see that the incidence or the risk of cancer is up to 40% higher than those who are not positive for this antibody, and then only 10% if you were negative. But not everybody develops cancer with dermatomyositis, right? So I have patients come in and say, oh, I heard that, like, you know, I'm going to develop cancer no matter what. No, this is not the case. It is higher risk, but it's not everybody. And so some of the work that we've done here, especially my colleague, Dr. Chris Meckley, who's another rheumatologist specializing in the myositis at the Myositis Center, looked at why certain patients who are positive for this antibody actually have a higher risk for cancer, and some do not. And we combine cohorts with Hopkins and also databases, our patient pool with Hopkins and also Stanford. And you can see that some of these patients, and not all, but I think this hints to why not everybody gets cancer, is that some patients see the general population, let's say your risk is 1.0, standardized incidence ratio for developing a cancer. And if you're positive, you're co-reactive. If you have both antibodies, the CCAR1, CCAR, then it looks like your actual risk is close to the general population. So maybe this is actually protective. And then for those who are not positive, the risk was high. So in the Stanford cohort, if you were TIF1 gamma positive and had dermatomyositis, your risk for developing cancer was 6.4 times higher than the general population, versus in the Hopkins cohort, it was like 5 times higher. And so I think, you know, this tells us that, again, not all patients with dermatomyositis get cancer, but if you are TIF1 gamma positive and you don't have this second antibody, then your risk may be even higher. But, you know, this is trying to give you the most up-to-date research in the literature currently. This was published in 2023, but there have been other studies that have come out as well. And I think it's important to realize that the most important is to having that very frank conversation with your physician, and always reassessing if you're not responding to a medication, then is there another reason why I'm not responding? Is it because there's an occult cancer, especially in dermatomyositis? All right, so I'm going to change gears, and we talked about that key association between dermatomyositis and cancer. Not everybody, but a certain percentage, especially TIF1 gamma. And then I think one of the key points I want to talk about for dermatomyositis is that it is much easier to diagnose. So if you have dermatomyositis and you're on this webinar, then you would probably tell me, well, you know, my physician didn't even need a muscle biopsy to diagnose me. And yes, that is correct. Because in patients with dermatomyositis, you can have this spectrum of having no muscle involvement and only skin. But the skin can be very severe. Like, you can have skin ulcers going down to the bone and get an infection. So this is no joke. You know, honestly, sometimes I feel so bad for my patients who have severe skin ulcers because it can be severe. But in this case, you know, this MDA5 associated dermatomyositis, you can have very painful ulcers here. We call kissing papules on the, you know, the flexor creases of the your fingers. And then for TIF1 gamma, which was the one that's associated with cancer, you can get this patch on the roof of the mouth that you can also see. But again, so if my patient came through as a new patient, and I'm looking at their hands, so whenever there's a question of, is this dermatomyositis? I have my patient get into a full gown, everything off except, you know, keeping bra and underwear on with the gown open in the back. And then I'm looking at all of their skin, including looking in their mouth to make sure I'm not missing any rashes that's very characteristic of dermatomyositis, because sometimes it can be a little bit challenging too to make a diagnosis. Sometimes it can be mistaken as psoriasis or other diseases, and this is why it's very important to do a thorough skin exam. The other classic skin manifestation of dermatomyositis is this swelling over the eyelids, and this is a recent publication from 2023 that was published by us in our cohort, that when patients have this swelling over the eyelids, we call periorbital edema, but it looks fluid filled. This can also be seen in dermatomyositis, and specifically TIF1 gamma. But this actually, as you can see, pre and post, completely resolved after their treatment. And here too, completely resolved after treatment. And this is interesting, but I've actually had a patient with dermatomyositis where she actually only had a little bit of swelling, so she didn't make it to this degree of involvement, but she had this redness and swelling like right on the eyebrow area. So her dermatologist biopsied this eyebrow top of it and was able to make a diagnosis. So, these sometimes it can be subtle and sometimes it can be really obvious, but it is important to make sure that that full skin exam is done to make sure we're not missing other rashes that are characteristic for dermatomyositis. Okay, another antibody that's associated with dermatomyositis is SAE. And this one is just all that we have to know here is that it's very rare, but is typically associated with more, refractory skin. You can see it's very red and angry. And then also seen with some nodules in the lungs. Again, highlighting it's a very multi-system disease. And of course, you can get muscle involvement where this is lighting up. Whenever this on that muscle MRI is lighting up like this, that means there's a lot of inflammation in the muscle, a fluid signal. And the reason I'm highlighting this is because, this is a more rare autoantibody, but my colleague published this in 2021 in our cohort of patients with dermatomyositis, Dr. Almeida, and we can see that, this, whenever you see someone who has very extensive skin involvement, we want to think about this autoantibody and also think about coincident cancer. And this was also replicated in a French study of 49 patients, where you can see that patients who had this antibody also had more skin necrosis here, and also very, diffuse redness over the flanks and things like this, and much higher risk of cancer as well. Now, if you already have dermatomyositis and you're on this call, then you may wonder, well, we know these autoantibodies and my doctor can check these. Okay, that's great. But does it also help me figure out as a physician and also as a patient, well, then I should not be taking XYZ drug because maybe I'll have a bad reaction to it, or maybe I'll have a better response. So I can tell you that we still don't know what drug is the best specifically for TIF1 gamma associated dermatomyositis or NXP2, different types of autoantibody associated dermatomyositis. But there was one study that showed that if you were SAE positive, then taking hydroxychloroquine, which is commonly or otherwise known as Plaquenil, is commonly used to treat even mild rheumatoid arthritis, actually had a much higher risk of having a skin eruption, an allergic response, basically. So I think certainly if you are SAE positive, you would want to consider not using hydroxychloroquine. Okay, now I'm going to change gears. We talked about dermatomyositis as one subgroup where you get the skin and the rash. Skin involvement with severe rash, sometimes it could be very mild rash, and also muscle weakness with the muscle inflammation, are the most classic presentation. Now, remember I told you there's this one subgroup that in the past 5 years has really emerged as being a specific subgroup of myositis, which is this anti-synthetase syndrome. Even when I was in med school, early 2000s, we heard about this syndrome, and it was that you had to have all of these 6 bullets. And ILD is interstitial lung disease, myositis meaning muscle inflammation, polyarthritis meaning inflammation in the joints, fever. Mechanics hands is basically this rash where you get cracking of the fingertips, and then Raynaud's phenomenon, what is Raynaud's phenomenon? It's named after Maurice Raynaud from the 1800s, where he noticed that this physician noticed that when patients on exposure to cold or stress, you get complete white discoloration because you're getting no circulation to the fingertips. And that is something that you see in this specific subgroup or anti-synthetase. But now, since, the original report of this type of syndrome. In the past, I would say 10 years, it is more appreciated that antisynthetase syndrome, that's a long word, is classically associated with just 3 of these things. But you have to have a positive blood test for it, but also myositis, arthritis, and arthritis, I don't mean osteoarthritis, like, degenerative arthritis. As we get older, most of our patients, including me, everybody will get arthritis as we get older because the cartilage breaks down over time. But polyarthritis meaning, a lot of joint inflammation similar to rheumatoid arthritis, and then lung inflammation or interstitial lung disease, ILD. And then this one is something we reported, and I want to highlight this because I think even rheumatologists and neurologists, pulmonologists, we don't really think about this, but I'm also bringing it up today in this webinar is because I want my patients to be educated about this. So heart is also a muscle, and just like our skeletal muscle, but it's heart muscle. And we know that patients with myositis can certainly get inflammation in the heart as well. And so I had a very motivated, excellent, she's now practicing rheumatologist, but fellow at the time, who was very interested in this. So we said, okay, let's look at our registry. But you can see, you're like, okay, 14 patients, is that even really meaningful? That's like less than 1% of our entire cohort, right? But the reason why it is still meaningful is that when our cohort started, we were not routinely checking for heart involvement. So this is really a biased 14 patients. These were patients who were actually so sick that had to be admitted to the hospital. And that's why we captured it in our registry or database of patients with myositis. But these patients, the most common group were this antisynthetase group, and then overlap myositis with a different connective tissue disease. And SSC is scleroderma, which is a different cousin of myositis, autoimmune disease. And why is this important? Because even after a rheumatologist or a cardiologist actually increased the immunosuppression, like giving you more steroids, giving you more medications to treat the inflammation, the 5-year survival rate was only 84%. And then the 5-year survival rate after diagnosis of heart involvement was 53%. And for us, this means we're missing this, and we don't want to miss this because it's definitely treatable. And so more recently, and I don't know why, we've also seen a much higher, and we're picking up on it more. We're more aware of it now, that these patients also developed arrhythmias. And it's not everybody with myositis, but it seemed like this overlap myositis group who are anti-Coup positive, again, a simple blood test that your rheumatologist or myositis specialist can check, and they tended to have more arrhythmias. And this is a patient's biopsy of the heart. Now, when they biopsy the heart, they go through the neck and they get a tiny piece. Of course, it can be patchy, but you can see these small cells that are invading into the heart muscle and causing inflammation, thereby causing weird palpitations in our patients and unusual, very fast rhythms in the heart that can lead to, unfortunately, sudden cardiac death. So out of these 3 patients, we actually had to put defibrillators in 2 of the 3 patients. All patients are alive, doing well, but again, highlighting that the heart cannot be dismissed in myositis. And we really need to be, as a rheumatologist, humbling experience, but really need to be more aware of it and check for it. Okay, so I think I wanted to highlight why I'm highlighting this again is to just bottle it up and show you this picture that yes, maybe, and in the past 5 years, maybe it really is time. And I think right now it is really time. I agree 100%. It is really time to put our heads together and be more multidisciplinary, ever more so than before in our patients with myositis, because not only can it affect skin, which is we need to work with the dermatologist, muscle, it could be rheumatology or neurology, but also heart. So I really need to be working with our cardiologist, because if my patient develops heart failure, then I need to work very closely with the cardiologist. And then also PM&R, because to build back the muscle and exercise. And so in rheumatology, we had a whole research conference in our scientific annual meeting where 20,000 rheumatologists go to every year. And there's a whole multiple sessions on what we call cardiorheumatology, meaning, and cardiopulmonary, which is something we've always worked with our lung specialists, but really to hone in on all the complications that can be seen from cardiac perspective, but also in a pulmonary perspective as well. Okay, so now I'm going to change gears and talk about treatment of myositis. As I was saying before, these are the main medications we use for the treatment of myositis. Usually we use steroids. And when I say myositis, I'm talking about globally. It could be muscle or skin, lung, right? But how do we decide which one do we use? And initially, we always tend to reach to steroids or prednisone, methylprednisolone, because we know that really dampens the inflammation in our patients anywhere in the skin, muscle, lung, joints. But we don't like to expose our patients to steroids long term. And that is why we have to make a very careful assessment of what organ is involved so I can make a decision of what steroid sparing agent, which are these agents like methotrexate or azathioprine or mycophenolate mofetil, that I'm going to use, And so how we make that decision is basically here. If I have a patient before me that has skin and muscle and they have dermatomyositis, but they also have lung involvement, then I'll be using one of these two agents because all the literature that's published out there, it looks like mycophenolate or azathioprine is really the best at treating prominent lung disease, including muscle and skin. So I would have to use that. But there are no head-to-head studies at this time showing which one is better. Hopefully we can do some comparative efficacy studies in the future and look at these large cohorts, like our myositis cohort has up like 3,000 patients with myositis. And so I think over time we can do these comparative efficacy studies, but we don't know as of yet, based on what is already published, which one is better. But we do know what's published is that these two agents are the best in lung. And then, of course, methotrexate is best in those who have concomitant joint involvement. And if someone is not doing well with one of these agents, after 3 months, we always give it a 3-month go. And then after they're not responding, then we actually add one of these agents like IVIG. And IVIG is commonly used if someone has problem swallowing. It's very good for the swallow muscles. And then we also use rituximab, which is, these are all, I'm sorry, I should have told you, these are all immunosuppressants, drugs that suppress your immune system. These are oral medications that do this, and these are infusion medications that do this. And IVIG is a blood product, but doesn't suppress your immune system. It actually is an immunomodulator, so you won't get infections from getting IVIG. But it is a blood product that someone else went to donate their blood. And it's not the red blood cells, like we give red blood cell donations to the Red Cross, but actually the plasma part, the clear part, and they filter that out and then give that part to patients with myositis. Now, in other neurologic diseases, IVIG is commonly also used to treat different diseases as well, but dysphagia just means problem swallowing. Now, rituximab is a CD20 agent, so it's a B cell depleting agent. So it gets rid of just these B cells that we think are important in driving the disease process. It's already FDA approved for rheumatoid arthritis, but this is another drug that we use to treat myositis as well. Okay, but I do want to highlight kind of the most recent clinical trials to date in myositis. The only FDA approved drug is really this IVIG or the prodrug trial, which was a phase 3 trial published in 2022. And there is one other drug, if I get really technical, that was grandfathered in, not because there was a robust phase 3 clinical trial, but it was grandfathered in from many, many years ago, and that's called Axar gel. But honestly, I have to be honest, I don't think that the company has received this FDA, indication on their drug, but it's not backed up by these phase 3 robust clinical trials. So I'm not going to talk about that at all today. But anyways, so the only drug right now that's FDA approved that is backed by strong evidence by a phase 3 clinical trial is IVIG in dermatomyositis. And this was again published in 2022, but I think FDA approval was July 2021. And what this trial was, it was 95 patients, and it was only in dermatomyositis, and you either got IVIG or placebo, but you had to have muscle weakness, at least 4 out of 5 strength. Basically means at least to have a bottom line for this bullet point that I need you to know is that you have to have at least mild muscle weakness and some skin involvement, very mild skin rash, but they allowed patients who were already on medications, like the ones that I showed you, those other oral immunosuppressants, and you could also be on steroids. And the endpoint was at 16 weeks, basically saying at 16 weeks, did you have an improvement or not? And the FDA was okay with this. If you had an improvement, that means this drug worked at 16 weeks. And what do we see in these patients who entered the trial? Again, as I was saying, moderate disease activity, but you didn't have to have a CK level that was high. You did not. And I think this is something that I was just having this conversation with my patient, and I can sense her frustration, right? But in dermatomyositis, and we know this, I guess being here 15 years and becoming a myositis specialist, that our patients with dermatomyositis do not have high muscle enzymes. So creatine kinase is a muscle enzyme that I'm sure you all aware in the MDA Association, Muscular Dystrophy Association, but it's a blood test that we can see if there's muscle inflammation. Normal muscle and CK level is less than 200, but our patients with dermatomyositis can have a CK of completely normal, or it could be 250, and they can be extremely weak. And I think we really need to educate other muscle specialists, that neurologists, rheumatologists, anybody, that in dermatomyositis, CK does not have to be high to say that you have moderate disease activity. I mean, look at this clinical trial. You can see that this patient here, anybody who entered the trial, CK was completely normal, and they were allowed in the trial. Why? Because they still had weakness. Here, MMT8 is a muscle strength score, and highest is 150, but you can see here, it was 119 in the IVIG group, and then in the 122 in the placebo group, meaning they were pretty weak. So, and those patients actually improved their muscle strength, as you can see here. Let me go back into this. There's a score, this total improvement score, that takes into account how the physician thought the patient was doing, how the patient thought they were doing, the muscle enzymes, all of these things, and they calculate a total improvement score. And patients who got IVIG had a much higher improvement score than those who got the placebo. And so that is very meaningful, because they didn't have to have a high CK, but they still had significant improvement. All right. So bottom line is, we know that the IVIG was FDA approved, and we were already using it for our patients with dermatomyositis, but now it's much easier to get approved with insurance. Now, they just recently published this in February, and you can see that what are the predictors? So basically, what are the factors that show that you will respond to IVIG if you have dermatomyositis? So in fact, remember I was talking about all the autoantibodies? I think that is very important for diagnosis and understanding what other organ involvement may patient develop, like prognosis. But for IVIG response, if you're going to respond to IVIG, yes or no, it didn't matter if you even had an autoantibody. Look at this graph here. Patients, 34.7% of patients didn't even have an autoantibody, which is possible in dermatomyositis and in myositis, but they still had a great response to IVIG. So it didn't matter for IVIG. So I think that's important. So if you're a patient with dermatomyositis and don't have a myositis autoantibody, and your doctor says, well, I don't know if you're really going to respond to IVIG, then I think it's really time to reconsider that, because even patients who didn't have an autoantibody actually responded. Okay, that was just the point for this slide. Now, I'm going to also change gears now, because that's the only FDA approved drug, but now I'm going to go into each different subgroup and then talk about some of the drugs that are really are exciting in this field right now. But before I go into this was just recently published that we worked together to look at all the global treatment guidelines for myositis, because I'm assuming maybe we might have some international audiences. And I think it also really gives an interesting perspective when we hear about what other countries are doing to treat dermatomyositis or myositis. But the key similarities is that, yes, we use the steroids about 1 to 6 months, and then do maintenance therapy with the immunosuppressant. And they also use IVIGs and biologics like rituximab and abatacept only for severe refractory disease. But the major differences was in dermatomyositis in Japan, They also use dapsone, which is something we don't really do at all in dermatomyositis in the United States. So I thought that was very interesting. But why I'm putting this slide in is to tell you that unlike rheumatoid arthritis, where there are very clear treatment guidelines, in myositis, we're not there yet. But it is time really to put our heads all together in an international collaborative effort to really put forth some consensus-driven standardized guidelines for the treatment of myositis. And hopefully that will come. I think we are at the cusp of doing that, especially with more trials coming out and more collaborations throughout. So in the next 5 to 10 years, I think you will see more dedicated treatment, global kind of consensus-driven guidelines in the future. Okay, so what are the promising therapeutics in myositis? So I know I talked a lot about dermatomyositis, and you'll be like, well, what about, necrotizing myositis and, IVM? And I will talk about that, but I do think right now in the field, there's been a lot more movement in terms of getting drugs approved for dermatomyositis. And the reason is that there's just so much more data that's published about understanding what is driving the disease process in dermatomyositis. So one of this is this case report that was published in 2014. It was the first case report that was published about using JAK inhibitors. And what is JAK inhibitors? So basically, it's a drug that blocks this pathway called interferon, which is a pathway that gets activated a lot in lupus, systemic lupus as well. But there was a case report out of Germany that a patient received a drug, ruxolitinib, for dermatomyositis, and they had been on IVIG and they didn't really do well. But once they were given this, their dermatomyositis completely went into remission. So this was the first report that, oh, maybe these drugs actually, by targeting that specific pathway, will actually, have patients with dermatomyositis go into remission. Now, before this, I would have to say, all the drugs that I showed you, like methotrexate, mycophenolate, this is really not directly targeted to one pathway. It's just dampening the entire immune system. And so this was one of the drugs that did that. And I'm skipping a lot of the work in the past 10 years that we did. But this was the final product of a clinical trial that we did. And it was really truly motivated and inspired by my patient, where she didn't respond to anything. And we tried the same drug, but a slightly different formulation called tofacitinib in a patient. And then it led to, and she had a wonderful response for her dermatomyositis. And it led to a clinical trial, a proof of concept clinical trial that we conducted here, and I was the PI on it. And here I'm showing you that these patients had an improvement score very quickly within 4 weeks of at least 40, which is moderate improvement in 10 subjects. Of course, there was some heterogeneity. These are each single patient here. But I say a picture is worth 1,000 words. Her skin rash was so severe. I mean, in the back, and you can see all this redness, angry. By week 12, this is all gone, all gone. And this was, patient had to be completely, to enter a clinical trial for the trial that I designed for this proof of concept trial using this drug. You had to be off of all medications, nothing. You couldn't be on anything except prednisone 20 milligrams or less. You had to get off IVIG, any other medication, only the pure effects of this drug. So we saw a very good response. And since then, after we published this, there have been multiple studies in the international community where they actually, you can see, we took a deep dive during the pandemic, and we saw that there were actually a total of 48 records that showed patients were treated with these type of medications, or JAK inhibitors. And there were 34 unique publications in adult dermatomyositis and 84 unique adult patients. And you can see cutaneous, meaning skin disease, all had improvement, just like we saw in our small proof of concept trial. And then also for muscle disease, patient had improvement, about 93% of the patients. And in juvenile dermatomyositis also. So it's interesting. I love working with Hannah. She's a pediatric rheumatologist at the NIH. But when I was doing my clinical trial, she was also doing hers, and we published around the same time. I think she beat me by a couple months, but she also showed in juvenile dermatomyositis that these drugs work to improve skin and muscle disease, similar to what we also showed. So we recently published this review on looking at the different treatment algorithms of when a JAK inhibitor would be helpful. Currently, because again, these are small studies and we don't want to jump and leap about recommendations, still these are first line, these medications like steroids and other immunosuppressants, and then third line is really JAK inhibitors. But I think this may change depending on some of the exciting data. One of the drugs is this new drug called brepocitinib, and this showed even better efficacy in dampening this signal that we commonly see in dermatomyositis, as I told you about interferons. And so, as you can see here, this brepo is 85% inhibition of that pathway that's very angry in dermatomyositis. And it was better than tofacitinib, which is a drug I used in our clinical trial. So why am I telling you this? Because right now, this is an ongoing phase 3 clinical trial that just completed. And it was a 1-year study. They enrolled 225 patients, multi-center international trial for dermatomyositis. And we will hear the results, I think, by fall. So this may be, if it is a positive trial, it may be another drug that patients with dermatomyositis can use to treat their disease beyond just IVIG, which, sometimes it can be a lot for our patients being stuck to the IV pole for 5 days, 2 to 5 days, getting an infusion therapy. This was a small study, phase 2, that Dr. Hector Chinaway led in the United Kingdom, and that was completed. We heard results of this. We haven't seen the paper yet of this in our rheumatology conference in the fall in 2024. And these are also other JAK inhibitor studies that are enrolling. And here, look at this. One of the interesting components of this one is a phase 2 study and then goes into open label in Europe. And this is for juvenile dermatomyositis, and they have to be treatment naive. They don't even need to have seen any other drug, and they can go into this trial. So I'm very excited to say that I think in dermatomyositis, there's multiple agents, and one hopefully we'll see results very shortly from. Now, this is still ongoing trial, but the phase 2 was published in Lancet, which is a very high impact journal, where it's an infusion drug that completely blocks that pathway directly, more directly than a JAK inhibitor oral therapy. And it definitely showed improvement, as you can see here. Placebo is here in red, purple. And then dazukapart, which is the name of the drug, is an infusion drug, showed significant improvement in the skin disease activity. But they're still trying to enroll patients with muscle. So we'll have to see what that drug shows. And overall, I think in dermatomyositis, there's some treatment considerations here as a summary. And, you can look at this review article with your, you could read it or for fun, or you could also talk about it with your doctor as well. But, I just want to highlight again, we separated out, is it refractory skin disease, refractory muscle disease, refractory joint disease, or refractory lung? And then we consider different treatments. All right, what about treatments in immune-mediated necrotizing myopathy? So that is another subgroup that I'm going to talk about. And that is a type of myositis that's most commonly mistaken for like a limb-girdle muscular dystrophy. And the reason is that you get proximal weakness, but you also get very high CK, right? Remember I told you CK less than 200, or creatine kinase muscle enzyme is normal, is less than 200 usually. But patients can have like 50,000, 60,000, 10,000, things like this. And there is a form of myositis that was discovered here at our Hopkins Myositis Center that actually a statin can trigger it and cause this autoimmune response in the muscle and cause severe weakness. And those autoantibodies, the two that are classically associated, I showed you, with HMGCR and SRP. But don't forget that if you have any family member who has myositis and they're like, oh, I do have myositis, and a biopsy showed that it's necrotizing. Where you have, necrosis or cell death of the muscle fibers. But remember, muscle fibers can always regenerate. But if they don't have these two autoantibodies and a physician says, oh, no, you don't have necrotizing, don't forget that other connective tissue disease patients like lupus, scleroderma can also have a necrotizing myopathy. And this, in sake of time, we looked at our lupus cohort, and we saw that 50% of the 16 available biopsies had a necrotizing myopathy. And this is why I say patients don't disregard patients who have another connective tissue disease, because they can definitely have necrosis in their muscle fibers. And also in scleroderma, we have noted this as well. About 20% of our patients with scleroderma and myositis also had necrosis of the muscle fibers. And how do we treat this? Right now, there's been some experts got together in the European Neuromuscular Center group workshop and said, okay, this is how we're going to treat patients with necrotizing myositis. And you can see here, it's a little bit different depending on your antibody, but most of the time you always start initially with steroids and then either use a oral immunosuppressant and either use IVIG or rituximab, which is the B-cell infusion therapy. And sometimes we also use plasmapheresis. What is plasmapheresis? It's a big ordeal, but you have to put in a big catheter in a important, and you usually have to do it in the hospital setting or an outpatient site where there's transfusion medicine available. And basically what we're doing is we're taking out the plasma in your body that is making these antibodies, because we think these autoantibodies in particular are driving the disease process. And so by removing it, we're actually helping with the muscle inflammation. And so this is what we did in 6 patients with immune-mediated necrotizing myopathy, and 40% had an improvement in their muscle enzymes, and all had improvement in their muscle strength. So I actually learned from even our French colleagues once when I went to visit them that in severe patients, they actually do plasmapheresis very frequently in France. I think in the US, we don't do this as much, but certainly at a tertiary referral center like us, we do this when some patients are not responding to treatment at all. So what about some of the future treatment pipeline drugs? One of them that is very exciting, I think, at this current time, the phase 2 trial showed that there was a signal that there was some improvement, is this drug called efgartigimod, and it's already FDA approved for myasthenia gravis and currently enrolling for phase 3, but they just actually finished enrollment like a month ago. And so we will see results of this. In Spain, at the European Rheumatology Conference just last month, the company also had some top-line data about the phase 2, some kind of not de-identified data, obviously. We don't know all the results, but it looked like there was some signal of improvement. So I think we're going to see some, hopefully, results from this phase 3 clinical trial for myositis by next year. This one is that, I'm just going to skip this. And what about IBM? I know IBM is such an unmet need, and we still don't know how to treat it. And it's very difficult because I see my patients, come to us, and, it just breaks my heart that I don't have any good treatment for our patients yet. And, in the past, if you look in the literature, they've given steroids, they've given IVIG, they've given methotrexate, any immunosuppressant, and really hasn't helped. And so there has been a shift in the past, 5 to 7 years about, well, why can we not find a treatment? And the thought is that because in IBM, there's the degenerative pathway, there's a lot of protein deposition in the muscle fibers of all these different types of proteins. And the thought is, well, why are we not trying to get rid of these proteins that make it difficult for our patients to have some type of response? And so we were very excited about this arimoclomol trial, but unfortunately it was a multi-center randomized international trial. And unfortunately, it was a negative trial, and they did publish this in Lancet Neurology in 2022. But while this was disappointing, it also highlighted that how we measure improvement in inclusion body myositis needs a lot of work, because in this endpoint, it was a functional rating scale, but maybe it was just not sensitive enough to detect change. And so right now, there's an ongoing phase 2-3 trial, actually, and it's based on this open label trial that showed some improvement by blocking this T cells here. These are the T cells that are invading IBM muscle tissue. And basically, by blocking this, you're able to show that there was, on muscle MRI, that patient had improvement in muscle size on the MRI. And so this is why they have decided to do a phase 2-3 trial. And hopefully we will see some results from that. Another phase 3 multi-center trial is sirolimus in inclusion body myositis. And we were a site where we recruited the study for the trial, and we will hopefully see some results from that. And as I said again, the other trial is this KLRG1 monoclonal antibody that I think most neurologists and rheumatologists are most excited about, because our goal is, first step is, let's try to prevent any further progression of IBM. And then hopefully concurrently try to find a different drug. Maybe it's this drug, we don't know, but to stop any further damage also, and cure the drug. It could cure the disease as well. So I think these are all the emerging therapies as a summary that we discussed. Some of them have showed, that it didn't work, but I think these are the kind of summary. And I'm sorry, I kind of went over by like 4 minutes, but I can stay a little bit longer too. This is our whole myositis center and my funding agencies, and that's it.
Thank you so much, Dr. Paik, for that informative presentation, and so thorough. You actually answered a lot of the Q&A questions that we had.
Good. I'm trying to look at
which is wonderful. That's why people come to the webinar. I do have a few quick follow-up questions for you, so let me just switch my screen over.
Oh, should I stop?
Oh, I think I got it. No worries.
Oh, okay.
All right, there we go. So just a few follow-ups. We did have quite a few questions on inclusion body myositis, so I'm so glad you covered that so thoroughly. We did have one question. Is abnormal itchiness a symptom of IBM?
Itchiness is not typical for IBM. If there is itchiness, I would definitely, engage a dermatologist and see if there's any, rash there. Sometimes they could even biopsy it, but itchiness is a little bit of an atypical, because itchiness we think about is there's these nerve fibers in the skin that make you itchy. So IBM really doesn't affect the skin. So there has to be something else going on. Yeah.
Okay, thank you. That's so helpful. Another question, it's a little bit of two parts. Does working the affected muscles increase the progression of myositis? And are there any recommended exercises you know of that might be helpful for someone with this diagnosis?
Yes. Is this just for IBM or is this for in general?
For myositis in general. This wasn't IBM specific.
Oh, okay. So I think, sorry, I'm just going to move this so I can see you guys better. So in myositis, I guess I had a picture of our physical therapist we work very closely with, but in myositis, we say, please do exercise from the beginning. That's a very old school thinking, and we have hundreds of papers showing now that exercise is safe in myositis. We don't want you to suddenly train for a marathon, but we do want you to work with a physical therapist from day one. You might be like, how do you expect me to do that? I can't even get out of a chair. Well, you can do chair exercises, with non-resistance, not like without weights, even just doing repetitive movements with your legs or arms. But it's very important, and it will not make your muscle disease worse. In fact, it'll make it better because you're exercising. Muscle is very vascular, and so exercising is very important. So I want to share a story. Like one of our first global conference in myositis, back in, I think, what was it, like 2015? No, 2013, maybe. I don't know. That was a while ago. Was in Sweden, and one of the largest myositis institutes internationally is actually in Sweden and in Stockholm, the Karolinska Institute. And they shared with us, when the Swedish patients go to this myositis center, first day, they see the physician, they do a muscle biopsy if needed, and they do all the assessments, and they're in the pool doing physical therapy that same day, because that's how important exercise is. Anyways, I just can't emphasize that more than enough. Yeah.
Wonderful. No, that's great. Thank you so much. I think we have time for one more question. How is precision medicine influencing care for people with myositis?
Oh, that's an excellent question. I think it's so exciting because I think, I guess it also depends on how you define precision medicine. But like, as I was saying, for dermatomyositis, how precise we are about actually characterizing which signal was the most active in dermatomyositis skin, muscle, helped us really target clinical trials that use drugs that block that pathway. versus I feel like maybe in necrotizing myopathy, we don't have as much of that information. And that's why I think dermatomyositis is a little bit farther ahead in that regard with multiple clinical trials in that space. But that's one thing, being precise about the underlying pathway that's involved in specific subgroups of myositis. And then using precision medicine in terms of overall globally, like using AI and understanding the trajectory of a patient's disease and understanding which drug may be better by looking at big cohorts like ours or other places where we have thousands of patients and look back and say, well, actually, if you had this type of myositis, it looked like methotrexate, if you used it within the first 6 months of disease, had a pretty good response, but we don't know that yet. So I think we can get very precise with all the new technologies out there. Yeah.
Wonderful. Thank you so much for those great answers and for your wonderful presentation. I know that our community really appreciated it. And thank you so much for your time today, Dr. Peck.
Yes, thank you so much for having me.
Wonderful. Thank you.
Should I leave or?
No, you're good. I'm just going to do my closeout slides here. Sorry about that.
No, okay.
This year, MDA is celebrating our 75th anniversary. This milestone has been made possible by generations of dedicated support from people living with neuromuscular diseases, their families, researchers, clinicians, volunteers, and donors who boldly drive our mission forward. As we look ahead, we remain committed to honoring this legacy, building on the impact we've made together, and continuing our momentum towards transformative progress for people living with neuromuscular disorders. To learn more, visit MDA75.org. Last but not least, we invite you to join the MDA community. Joining is free and will help you stay up to date on programs as well as on the latest research. Please scan the QR code with your smartphone or visit the link in the chat. We would again like to thank Dr. Pack for sharing her time and expertise with us today, and we do want to hear from you. What did you like about today's program, and what can we do differently in the future? Please fill out the brief survey that will pop up right after the webinar. If you have any questions or are looking for support or resources, please contact MDA's Resource Center at 1-833-275-6321 or at the Resource Center at mdausa.org. This will conclude our webinar today. Thank you so much for joining us, and thank you again to Dr. Pack for her time and for everyone who attended. We will see you again next time. Thank you. Goodbye.
Thank you.